Welcome to the NCLEX Crash Course. In this series, we'll cover topics like pharmacology, medical surgical nursing, pediatric nursing, obstetric and gynecological nursing, and psychiatric nursing. Don't forget to subscribe for more valuable NCLEX Crash Course episodes.
In continuation with the previous video, we will discuss about some more major disorders of gastrointestinal system. So let's start this wonderful session. I hope that you will be seated till the last and you will watch this video with your full focus. So let's begin. So let's start with cancer of stomach. So you can see here that in stomach, cancer can occur anywhere, and if the diagnostic evaluation is done, so we can see the growth of the tissue at some part, that is cancer of stomach, and this can metastasize or spread to other parts of the stomach and intestine. So let's see etiology and pathophysiology. What can be the risk factors of cancer of stomach? So there is a bacteria called Helicobacter pylori in the stomach. This bacteria is also the risk factors of peptic ulcers, that is ulcer in the stomach, and repeated ulcer of the stomach leads to damage of the tissue and can stimulate the cancer producing tissues in the stomach. That's why it is a risk factor. Others are ingestion of smoked meats. So smoked meats carry the cancer properties, so these can be risk factors of the cancer of stomach. Salted fish. Okay, so salted fish can also be the risk factor. Processed food containing nitrates. So we can see here that there is something that is stimulating or aggravating the cancer. That can be nitrates, processed foods, salted fish, smoked meats, and it can be due to smoking. It can be heredity, so it can pass from the generation to generation. Disorders such as ulcerative disease and pernicious anemia. So if there is ulcerative disease, as I've mentioned, that if there is peptic ulcer in the stomach, that can lead to the cancer. And pernicious anemia. So pernicious anemia is deficiency of vitamin B12. So when the vitamin B12 is deficient in the body, it can lead to some autoimmune condition, and that autoimmune condition can lead to cancer or tumor formation. So all these are the risk factors of the cancer of stomach, that is H. pylori, ingestion of smoked meats, salted fish, processed food containing nitrates, smoking, heredity, and ulcerative disease and pernicious anemia. Now moving on to the incidence. So what is the incidence of cancer of stomach in the people? So it is higher in men older than 40 years of age. Okay, Japanese people have greater rate of cancer of stomach than Americans. So this is the incidence which has been confirmed by many researchers. Often not diagnosed until metastasis occur. Now here we have to remember that because stomach cancer do not show acute signs or symptoms very at the early stages, therefore the person will identify something is wrong in the body when the metastasis will occur. Stomach accommodates growth of tumor. Pain occurs late in the disease. So because the pain occurs late in the disease, so it is very difficult to identify the stomach cancer at the early stages. So the person might think that it is it is due to some other reasons, not due to cancer. It may metastasize by direct extension by lymphatics or blood to esophagus, spleen, pancreas, liver, or bone. Okay, so it can spread to the other organs by direct tissue to tissue contact, or by the lymphatic circulation, or by blood circulation to the following organs as mentioned. For example, stomach is connected to esophagus, spleen, pancreas, liver, or the bone. Now moving on to the clinical findings, how we are going to assess, how we are going to see and confirm that the person is having stomach cancer. So in subjective data, which means the patient will give information that patient has lack of interest in the food, that is anorexia. It means that patient will have loss of appetite. It will be certainly due to the tumor formation, which has lead to decreased residual capacity of stomach, and that's why anorexia. Nausea will occur. So due to gastric change in the stomach, the nausea will occur. Belching. Belching means release of the gas from the esophagus. We have discussed this in the previous video that it is similar to burping. Heartburn. So dyspepsia can occur, or we can say pyrosis. This can also occur, and the patient will report all these things, but it will be not confirmed by these manifestations, clinical manifestations, because these are the symptoms which can be present in other diseases also. So we have to go forward to the objective data, what we will observe in this patient. So we will observe weight loss. Okay, so there will be rapid weight loss due to anorexia, lack of interest in the food, nausea, and due to the heartburn. Stools positive for occult blood. Now this is very important, as there is tumor in the stomach, so there may be some amount of bleeding, there may be metastasis, so there will be occult blood seen in the stool. We have to ask this in the patient's history. So there can be anemia due to blood loss. Anemia can occur. Absence of hydrochloric acid. So hydrochloric acid release indicates that stomach is functioning properly. But here, as the stomach is having a tumor growth, so the stomach will not able to function properly, and there will be absence of HCl. Patient will have pale skin due to anemia and acanthosis nigricans. What is acanthosis nigricans? It is a hyperpigmented, velvety thickening of skin in the neck, axilla, and groin. So this we have to remember. This is very important, that in patient having stomach cancer, acanthosis nigricans can be seen, which is a hyperpigmented, that is dark pigmented, velvety-like texture of the skin at the neck, axilla, and groin. We will see in the next slide where I'll show you. So this is the appearance of the acanthosis nigricans, in which there is a dark, that is hyperpigmented region, and this can occur in the axilla, groin, and on the neck. Now moving on to the therapeutic interventions. So in the patient having stomach cancer, what are the therapeutic interventions that we will provide? So first is surgical resection. So as there is a tumor growth, so there can be removal of the tumor. There can be radiation therapy before and after the surgery. So if the tumor is not that much large, if it can be, shrinked or reduced or removed by the radiation therapy, so that can be done also. And it will be done before and after the surgery. So it is combined with the surgical resection. Chemotherapy before or after surgery. So surgical resection, radiation therapy, chemotherapy can be combined with each other, and they will be done before the surgery or after the surgery, and can be done at both the time. Next is chemoradiations. So radiations, that is chemical radiations, will be provided on the tumor growth to remove them. So these are the therapeutic interventions. Now moving on to the nursing care of clients with cancer of stomach. Here comes the important part for us, that what are the things we have to take care of the patient having cancer of stomach. So let's start with the assessment and analysis. What we are going to find out, what we are going to point out in the patient having stomach cancer. So first thing is in the assessment is we have to take history. We have to take a detailed history of causative factors. What are the factors that have led to the cancer of stomach, so that we can tell the patient to avoid them in the future. So that those things will be contraindicated. For example, if patient was smoking, if patient was using processed foods. So all these things we have to educate to the patient, and we have to tell the patient to stop them. And we will ask about the pain, that when the pain occurred, what was the characteristic of pain, what was the duration. Weight loss. So we have to also know about the weight loss because we are assessing the patient. So we have to take every aspect of the disease of the stomach. So if there is anything related to the stomach, so we have to include every aspect. We have to ask about weight loss so that we can understand that what is the cause of the cancer of stomach. Second is we have to see axillary lymph nodes and left supraclavicular nodes for hardness indicative of metastasis. So if there's cancer of stomach, so we can assess the patient's other organs, other parts, so that to confirm if there is spread of the tumor or spread of the cancer to the other body parts. So if there is nodes in the axillary or in the supraclavicular region, that is left supraclavicular node, so these two findings we have to check for the hardness. Next is skin for color and lesions associated with cancer of GI tract. So there may be some kind of lesions that may appear in the patient having cancer of GI tract. For example, we have talked about acanthosis nigricans. So these, sign of this skin disease can be seen in the patient. So we have to also assess this. Moving on to the planning and implementation, how we are going to plan the care, that is nursing care for this client, and we have to implement these things in the client's care. So we have to encourage verbalization of fear. Now here we have to remember that patient is of cancer. In patient who are having cancer, we have to make sure that patient is mentally stable. We have to make sure that patient verbalizes all the feelings so that the body image can be or self image can be coped up, and there should be no depression in the patient. So we have to encourage the verbalization of fears. This is very important here. For example, we have to tell the patient about to talk about the cancer, death, family problems, self-image. All these things, all these issues should be talked about so that the patient will be able to ventilate all the feelings and he should be familiar with the true facts. Next is provide nursing care after gastric resection. So if patient had a surgery where the tumor was removed or the part of the stomach was removed, so what is the nursing care we will give to the patient? So if a total gastrectomy is performed, the chest cavity usually is entered and chest tube are inserted. So we have to see here that in gastrectomy, if there is total removal of the stomach, in that case, the entering zone will be from the chest cavity. So chest tubes are inserted. So we have to see this. Next is we have to modify diet to include smaller, more frequent meals. Now it is for every stomach disease. We have to tell the patient to have small frequent meals so that the ingested food can be easily processed, it can be easily digested, and there will be decreased load in the stomach. If a total gastrectomy is performed, vitamin B12 deficiency results are seen. Okay, so it is to remember that stomach is responsible, the gut is responsible for absorption of the vitamin B12. And more importantly, the vitamin B12 is absorbed in the small intestine. But here we have to remember that stomach is responsible for formation of vitamin B12 because it produces the intrinsic factor. Therefore, so we have studied this in the GIT system that stomach is responsible for production of intrinsic factor. Therefore, the removal of stomach will lead to deficiency of vitamin B12 because intrinsic factor is responsible for the formation of vitamin B12. So deficiency will be surely seen. So we have to see this in the patient and we have to provide the supplementation in these patients. Administer gavage feeding as ordered. So gavage feeding can be given if ordered to the patient. So what is the gavage feeding? It is administration of food and medicines and liquid diet through the nasal passage or oral passage, but it should be given in the liquid form because the stomach is not able to digest to function properly. Therefore, the gavage feedings will be given. Now, moving on to the evaluation, what we are going to expect, what will be our outcome. So, patient states relief from discomfort and pain. This will be our evaluation that the patient reports that he is feeling comfortable and there is no pain. Second thing is the patient is maintaining adequate nutritional status. So, as we have included small, frequent meals, we have included gavage feeding, we have seen and we have looked into vitamin B12 deficiency. So, we will make sure that the nutritional status will be adequate. Verbalizes feelings. So we will make sure as the patient is having stomach cancer, so the patient will be mentally stable and will verbalize the feelings. Now moving on to the next disease, that is polylithiasis. What is polylithiasis? We know that polylithiasis or cholecystitis is gallstones blocking the gallbladder, or it can block the common bile duct. So as the name indicates, choly means gallbladder and lithiasis means stone. And here, cholecystitis means inflammation of the gallbladder or common bile duct. So moving on to the clinical findings, what we will see in this patient. So if we talk about the subjective data, so patient will complain that indigestion after eating fatty or fried foods, pain usually in right upper quadrant of abdomen. So these are the special symptoms, or we can say specific symptoms in patient having polylithiasis, that there will be pain which will be in the right upper quadrant. Okay, so the pain will be at the right upper quadrant where the gallbladder lies. So as our stomach is divided into 4 quadrants, so right upper quadrant is this one. And which may radiate to back. So this pain may radiate to the back and there will be nausea or itchy skin. So these are the symptoms that will be reported by the patient. Now moving on to the objective data, what we are going to assess, what we are going to see in the patient. So there will be vomiting. There can be vomiting, increased temperature and WBC count. So as there is gallstone, this can be considered as the foreign body by our immune system. So whenever there is foreign body, our body provide response with increasing white blood cells to fight, and when white blood cells are increased, so automatically the body will increase the temperature of body. Okay, so in response to the infection, considering it as infection, the temperature will increase. Clay colored stool. So in the gallbladder stone, due to the dysfunctioning, or we can say reduced function of the gallbladder, there will be effect on the production of bile, okay, or storage of bile. And that affection in the storage of bile can lead to poor colored stool. Stool are generally yellow or mustard color, but here it will be clay color due to deficiency of bile. There will be dark urine. So as bile will be deficient, the urine will be dark and jaundice may be present. So all that yellowish, that bilirubin will deposit on the skin. We can see rebound tenderness in abdomen increasing on inspiration. So there will be tenderness that will rebound in the abdomen and it will increase when patient will inspire, indicating peritoneal inflammation. So this will indicate that there is inflammation or swelling in the peritoneal cavity. So all these symptoms we will see in the patient. Now, what are the diagnostics tests that we can perform in this client? So we can advise for serum bilirubin test, and alkaline phosphate levels are increased. So as there is stone in the gallbladder, so automatically or simultaneously the liver will be also affected. So to check the liver functioning, serum bilirubin or alkaline phosphate levels are seen, that will be increased in the patient. Ultrasonography determines presence of gallstones. So obviously the UCG will reveal the gallstones. Other thing is endoscopic retrograde polyangioppancreatography, that is ERCP. This is the modern diagnostic test which is done in the hospitals. It reveals the exact location of the gallstone and the size of the gallstone. So these are the three diagnostic tests that we will advise to the patient. Moving on to the therapeutic interventions. So what are the management that we will provide to the client? So moving with medical management. So first we try to treat gallbladder stones with the medications. So first thing is nasogastric tube suctioning to reduce nausea. So when the patient will admit, our goal are always shifted to the first to the short term goals and then to the long term goals. So when we make the goals, so we will see the symptoms. We have to first reduce the symptoms of the patient to provide comfort. Once the short term goals are achieved, we will focus on the long term goals. So as the patient will complain nausea, so NG tube suctioning will be done to reduce nausea and to eliminate vomiting. After that, the focus will be on pain, as patient will be complaining pain because in gallbladder stone, pain is seen, which can be from mild to moderate and it can be severe pain also. So in that case, we can give opioids. This is a drug of choice, and it is given to decrease pain by relaxing smooth muscles. So as I mentioned that in gallbladder stones, the pain can be severe. That's why opioids are required. Other than these things, antispasmodics and anticholinergics are given to reduce gallbladder spasm and contractions. So, due to presence of gallbladder stone, there will be contractions in the or spasm in the gallbladder. That's why antispasmodics will be given so that there will be comfort to the patient. And moving on to the long-term goal. So, as there is infection suspected because there is a foreign body, and due to foreign body the autoimmune system will activate, so there can be chances that we need to start antibiotic therapy. So this will be also started. So talking about NG tube, opioids, antispasmodics and antibiotic, next thing we will give is vitamin K to prevent bleeding. Vitamin K is a fat soluble and is not absorbed in absence of bile, and a deficiency may result in bleeding. Okay, so vitamin K is given to prevent bleeding because there is a foreign body, there is a stone which can rupture the membrane. That's why it is given. And good thing is that vitamin K is a fat soluble and it is not absorbed in absence of bile. Okay, it is not absorbed in the absence of bile, and a deficiency may result in bleeding. Therefore, it is required in the patient. Now, when the surgical risk is high or radiolucent cholesterol stones are small, chenodeoxycholic acid, that is chenodiol or ursodiol, administered for 6 to 12 months to dissolve the stone. So these are the two drugs that are commonly given in the patient having gallstones. So these help in dissolving the stones and they take 6 to 12 months to do so. So whenever we assess the patient, we see that if patient is, compliable to the surgery, then we will advise the surgery. But if patient has risks in the surgery, then we can advise for the ursodiol or chenodeoxycholic acid, that is chenodiol. So these will be the medications. Dissolution of stones by infusing a solvent such as methyl tertiary terbutyl ether MTBE into the gallbladder through ERCP. So this is also a method where there will be infusion of the solvent. There will be a solution that will be infused in the gallbladder by the ERCP. So we have talked about ERCP. As we can see here, this is the endoscopic retrograde cholangioppancreatography, where the solvent will be induced or it will be introduced in the body by this method. Next is endoscopic papillotomy by ERCP to retrieve stones in the common bile duct. Okay, so this can be also done and it will be done using ERCP also. This method is endoscopic papillotomy. and it will help in retrieving the stones in the common bile duct so that they do not move further and they do not damage the other organs. Next is electrohydraulic shock wave lithotripsy, that is ESWL. So what is the electrohydraulic shock wave? So as the name indicates that there are some, waves. There is something electric which will break down the stones. Lithotripsy means that there will be breaking down of the stone. So it is fragmentation of stones by ultrasonic sound waves enables their passage without surgical intervention. So this is a modern, intervention where there will be production of the ultrasonic waves that will break the stones into small pieces that will be, excreted by the urine. Okay, so this do not need the surgical interventions. So all these things we can do. We can start from the medications, and then we can use a solvent. We can use the, shock therapy. Other thing is low fat diet to avoid stimulating gallbladder. These therapeutic interventions should be also included. So low fat diet is, advised to the patient because it will reduce the stimulation of the gallbladder, which contracts to excrete bile with subsequent pain. So when it tries to excrete the bile, it contracts, that will lead to pain. So if we give fatty food to the patient, so this will put load on the gallbladder to produce more bile. And when there will be load, there will be contraction. And when there will be contraction, patient will feel so much pain. That's why to reduce the pain, the diet should be low fat. Calories principally from carbohydrate foods. In acute phase, calories may be reduced to 1000 to 1200 if weight loss is indicated. So if we provide a low fat diet, so we have to tell the patient to reduce fat and to increase good carbs and protein. And if weight loss is advised, so calorie reduction can be done to 1000 to 1200. Post-operatively, a fat restricted diet is initiated and progressed to a regular diet. So as with the other surgeries, after the operation, we know that gallbladder is in a recovery phase. Therefore, we will avoid putting load on the gallbladder. So we will suggest a low-fat diet, and then we will subsequently provide regular diet with the time. Now, moving on to the surgical interventions. So, what kind of surgery? How we are going to remove the stone by the surgery? So, first is abdominal cholecystectomy. So, as the name indicates, that there will be removal of the stone by opening the gallbladder. So, there will be abdominal incision given, and there will be removal of gallstone or gallbladder. Okay, so there will be total removal of the gallbladder by the abdominal incision. So as the name suggests, cholecystectomy. So whole gallbladder will be removed. Laparoscopic cholecystectomy. This is the same thing, but it is done by the laparoscopic device. Removal of gallbladder through endoscope inserted through abdominal wall. Now this is commonly done nowadays. This is better than the abdominal incision. In this laparoscopic procedure, the incisions are given very small, so the recovery is very fast. So removal of gallbladder through endoscope inserted through abdominal wall, also called endoscopic laser cholecystectomy, not used in infection is present. So if there is infection, then we will not use all these kind of things because this can lead to increase in the infection. Other thing we can do is choledochotomy. What is choledochotomy? Incision into the common bile duct for removal of stones. So as we have seen in the picture, if there will be stone in the common bile duct, then the procedure we will do is the choledochotomy. So these were the surgical interventions. Now moving on to the nursing care of the patient, we have polylithiasis or cholecystitis. So we will see first the assessment, then the interventions, and then the evaluation. So let's start with the assessment. So first of all, if patient has gallbladder stone, then pain is the most common symptom. The sign will be pain. Therefore, we have to know the characteristic of pain. If pain is on the right upper quadrant, if pain is radiating to back, all these things we have to ask to the patient. Pain in relation to ingestion of foods high in fat. So patient will tell that yes, when I take heavy diet, when I take fatty food, then there is more pain. Pain on inspiration while examiner's finger are touching site of the gallbladder. This is Murphy's sign. This is very, very important. We have to remember this. So what is Murphy's sign? It is seen in the patient having gallbladder stone. What will occur then when patient will, advise to take the breath in? We will tell the patient to take the breath in, and examiner will put the finger on the side of gallbladder. And when the patient, the examiner's finger will be on the gallbladder, and when the patient will palpate, then the patient will, complain the pain. So pain on inspiration while examiner's finger are touching site of gallbladder, and this is due to peritoneal inflammation. So as this is a mechanism when patient take the air in, so our abdominal cavity increases and peritoneal space increases. So when this occur, peritoneal space increase, so there will be pressure on the gallbladder. So when there will be pressure on the gallbladder, it will lead to pain. Then the thing we will assess is stools for color. So the color of stool will be clay color, and they will be steatoria. Steatoria means there will be fat in the stool. Urine for color. So we will check the urine. The urine will be dark. So these things we will assess. We will assess pain. We will assess pain related to the food. We will assess the Murphy sign. We will assess the stool for presence of fat, for presence of clay color, or we will assess the urine for dark color. Then we will, advise the patient for laboratory values. We will tell the patient to do laboratory test, and we will see we have, seen earlier alkaline phosphate. We will see the, bilirubin level in the body. So liver function test will include all this. So we will do these tests in the patient. So this is how we will assess the polylithiasis in the patient. And now here, we will teach dietary modification to achieve low fat intake initially, because reduced bile flow will reduce fat absorption. So the heading is not here, but this is the planning or nursing intervention. What we will plan for the patient and what will be the implementation. So as this is a case of gallbladder stone, so we have to teach dietary modifications. We have to advise low fat diet so that there will be reduce of the bile flow, which will reduce fat absorption. Supplement with water miscible forms of vitamins and ER prescribed. So as there is low bilirubin, so the fat soluble vitamins will be not able to absorb. So we will advise the water soluble vitamins like A and E. We have to remember here that vitamin A and E are fat soluble. So we know that vitamin A, D, E, K, these are all fat soluble vitamins. So in the case of gallbladder stone, as there will be reduced bile flow, so all these fat soluble vitamins will be not able to absorb. That's why it is written that we will advise the water miscible forms. So all these fat soluble vitamins will be given through the other form, that is water miscible forms, so that their deficiency do not occur in the body. Next is we will try to relieve pain pre-operatively and post-operatively, administer opioids as prescribed. Then we will administer vitamin K as prescribed to reduce bleeding, and we will provide care after cholecystectomy. So what care we will provide after the surgery? If the whole gallbladder is removed, what is the nursing care we will provide? So first of all, we will monitor nasogastric tube attached to suction to prevent distension. So whenever the NG tube is attached to the suction, we have to monitor that to prevent distension, so that there will be no distension of abdomen and the extra gastric content can be removed. So to monitor that, to look for that, we have to maintain patency of tube. And we have to make sure that the NG tube is kinked well. When not in use, it should be kinked well so that the air do not enter in the tube. Second thing is we have to always see if the NG tube is placed in the stomach. This is very important because if this is not placed in the stomach, so there can be aspiration and further complications. Second thing, we have to assess and measure the drainage. If we know that what amount of drainage is there, then we can know if there is a good amount of suctioning and there is a proper, NG tube suctioning done. Second thing is provide fluids and electrolytes by intravenous route. So as the patient's gallbladder stone, due to gallbladder stone, the functioning has reduced, the patient is not taking enough amount of nutrition. That's why we need to replace fluids and electrolytes to maintain that. So in that, we have to monitor the intake and output. As we are providing fluids and electrolytes, we have to see if the amount that is we are inputting should also be getting out. That should be also giving the output. So this will indicate that the kidney functioning is good. Second thing is we have to check the IV site for redness, swelling, heat, or pain. So this is applicable for every patient, for every disease. Whenever patient is on the IV therapy, that is intravenous route, medication, then we have to check the IV site for redness, swelling, or heat or pain, which can indicate the phlebotomy. So these things should be also seen. Maintain in low follower position. So this thing we have to also see that in patient having this gallbladder stone, the position should be low follower. This will be good for the patient having gallbladder stone. Encourage coughing and deep breathing. Splint incision. Incision is high and midline, making cough painful. So this is the thing, especially in the gallbladder stone. So when the patient after removal of gallbladder comes to the post-operative ward, then we will assess that the incision will be splint, which means the incision is high and midline, making coughing painful. So whenever we will see that patient is coughing and deep breathing, so we will see that patient will complain the pain. In that case, you have to tell the patient that always use pillow on the side to put pressure so that there will be no disruption of the incision or no, breaking the dehiscence of the incision. Provide care related to T-tube. If common bile duct is explored, T-tube is inserted to maintain patency. So if in the case there is stone in the common bile duct and if it is explored, then there is T-tube, that is tracheostomy tube placement to maintain the patency. So we have to provide care related to that. So in that case, we have to secure drainage bag, avoid kinking of tube. Okay, so we have to avoid kinking of tube. We have to measure drainage routinely, that is 8 to 12 hours. Drainage during first day may be 500 to 1000 ml and then gradually decreases. Apply prescribed protective ointments around tube to prevent excoriation. So we have to always maintain the integrity of skin. Therefore, the ointments can be applied around the tube to prevent excoriation. When tube is removed, usually in 7 days, observe stool for usual brown color, which indicates bile is entering duodenum. So after the gallbladder removal, we have to see after the 7 days of the surgery that the liver is functioning properly and the stool color is established again. In case if you don't know that what is T-tube, so I must tell you that when there is removal of the gallbladder, so we can see here that this is the liver, this is the stomach, and this is the pancreas, and this is the gallbladder here. So when the gallbladder is removed, and if there is exploration of the common bile duct also, this is the common bile duct, and then if there is exploration and opening of the common bile duct, so Due to incision on the common bile duct, there is a problem because the common bile duct is carrying bilirubin. So provide healing, to promote healing, what we will do that we will use a T tube. We'll put a drainage tube here. So drainage tube will be put here and it will be connected to the outside of the body, and the bilirubin will be drained outside. So this is a tube put into the bile duct after surgery. It's shaped like a letter T. It helps to drain bile while the duct is healing. The tube may drain into a bag that is attached to your body, and a bandage is on the site where the tube is placed. This will protect the open area from infection. The T tube will be left in the place for several weeks. Okay, so this is about the T tube. Now moving on to the evaluation. So what are the results that we expect? The patient will verbalize decrease in the pain. There will be maintenance of nutritional status in the patient. So this was all about the gallbladder stone or polylithiasis. Now moving on to the next disease, that is acute pancreatitis. Acute means that the problem or the disorders occur before the 6 months. That is acute. But when the disease is prolonged up to more than 6 months, that becomes chronic. So in acute pancreatitis, as we can see, this is the healthy pancreas, and here there is swelling and inflammation of the pancreas. That is pancreatitis. Itis means inflammation. So this is inflammation of the pancreas. So let's see etiology and pathophysiology. Inflammation caused by autodigestion. Now, this is the term we have to remember here. Inflammation caused by autodigestion by pancreatic enzymes. So, pancreatic enzymes, which is mainly or primarily trypsin, when it starts autodigestion, that leads to the pancreatitis. Now, what is autodigestion? Autodigestion is a process where the pancreatic enzyme will, digest, or we can say they will destroy the own tissues. When the pancreatic enzyme will destroy own tissue, that will lead to the inflammation. So this is autodigestion, and this will lead to acute pancreatitis. What are the risk factors? So risk factors can be due to presence of gallstones, due to alcoholism, carcinoma, acute trauma to pancreas or abdomen, or hyperlipidemia. So all these are the risk factors which can lead to the inflammation of pancreas. Inflammation with or without edema or pancreatic tissue may precipitate suppuration, abscess formation, hemorrhage, necrosis, or duct obstruction. So in case if there is inflammation, it can be with or without edema of the pancreatic tissue, and that can lead to other complications that can be the pus formation, there can be abscess formation, there can be bleeding, and further necrosis or duct obstruction. So we have to prevent all these complications in the patient. Moving on to the clinical findings. So what are the complaints of the patient? What will be the subjective data? So there will be abrupt onset of aching because it is an inflammation of pancreas. So due to that swelling, there will be pressure on the wall of the patient's stomach, and that can lead to abrupt onset of the aching. It will cause burning, stabbing pain, or pressing central epigastric pain, and it may radiate to shoulder, chest, and back. So this is about the clinical findings that the patient will complain. So there will be a stabbing pain. The patient will complain that there is a pain in which the patient will feel that someone is putting or the patient is stabbing a knife in the wall. And other than this, there will be abdominal tenderness, nausea, pruritus associated with jaundice. Now, this is very important here, that in patient having pancreatitis, there will be dysfunctioning of the liver, the gallbladder. There will be presence of jaundice, which can lead to pruritus, which is a skin infection that we will see in the nursing care of patient having pancreatitis. Moving on to the objective data that we are going to assess in the patient. What we will observe Due to inflammation, there will be increased temperature. There will be shallow respirations. There can be vomiting, weight loss, change in the character of stools, that is steatorrhea. So, due to pancreatitis, there will be affection in the production of bilirubin that can lead to fat, a presence of fat in the stool. Now, moving on to the other symptoms. So, tachycardia can be seen as there will be shallow breathing. So, patient will be seen with tachycardia, hypotension, or there can be shock. There can be presence of jaundice, grossly increased serum amylase and lipase. So, amylase and lipase are the two enzyme of the pancreas which will increase due to the disturbance in the pancreas. There will be decreased serum calcium level. So, patient having pancreatitis, the calcium level will be decreased. Now, you will wonder that why calcium level will decrease here. Reason of hypoglycemia in patient having pancreatitis is still unknown, but we have seen that hypocalcemia seen in early phase are autodigestion of mesenteric fat by pancreatic enzymes and release of free fatty acids, which form calcium salts, and later stages of pancreatitis are frequently complicated by sepsis, which becomes an important contributor to hypoglycemia. That's why we have to see here that the calcium is very helpful in the functioning of the SNR cells. So in pancreas, there are SNR cells, and the functioning of these cells, the function of the pancreas occurs due to the calcium, presence of calcium. But in pancreatitis, we can see that the hypoglycemia will occur. So we have to also look into it. Abnormal pancreatic findings on computed tomography scans. So we can also recommend CT scan to see the abnormal findings of the pancreas. Board-like abdomen associated with peritonitis. So due to the swelling of the peritoneum cavity, the abdomen will become board-like, which means very hard. Also, we will see that if we look into it, severity depends on cause of problem, amount of fibers replacement of healthy duct tissue, degree of autodigestion. If patient is having pancreatitis, so the severity will depend upon the cause of problem. What is the cause? If it is due to smoking, if it is due to the gallstones, so all depends upon this cause of problem. And amount of fibrous replacement, what is the diet of the patient? It also depends upon that. Degree of autodigestion, what is the amount of autodigestion is happening in the pancreas? Type of associated biliary disease if present. So if there is any biliary disease, then it also depends that what kind of severity it will create. And amount of interference in blood supply to pancreas. So if there is any disruption in the blood supply, so severity will be more. Complications may occur such as pseudocyst. So there can be formation of pseudocyst, that is dilated space containing blood. So these, blood cyst will be the complications. Necrotic tissue can occur in the pancreas and enzymes. Abscess formation can occur and pancreatic fistula can form. So these complications can be seen. Now moving on to the therapeutic interventions. What will be the management of patient having acute pancreatitis? So first of all, antacids will be given to neutralize the gastric secretions. Okay, so whenever there is the, any kind of abnormality in the gastrointestinal tract, so the first thing is we have to, let the gut rest. So the gut will rest when there will be less food, when there will be less acidity. So antacids will be provided. Opioids will be given to control the pain. Bed rest will be advised to decrease metabolic demands and promote healing. Nothing per oral is, advised, and nasogastric decompression to control nausea. So the patient will have feeling of nausea, so all the gastric content will be removed to control it. Reduce stimulation of pancreas to secrete enzymes. Okay, so NG2 will be done so that there will be reduced stimulation of pancreas to secrete enzymes and remove gastric hydrochloric acid. Other thing is anticholinergics will be given to suppress the vagal stimulation. So vagal stimulation will be suppressed because the patient will have a lot of nausea feeling and decrease gastric motility and duodenal spasm. So to reduce this motility and spasm, anticholinergics will be given. Antibiotics can be given to prevent secondary infection. So whenever there is inflammation, infection can occur. So antibiotic will be started prophylaxically and to prevent the abscess formation. Pancreatic rest until pain has diminished. So to provide pancreatic rest, we all know, we have seen in many diseases that our priority should be to maintain a low calorie, maintain a low fat, very lightweight diet. So pancreatic rest until pain has diminished and bowel sounds return. Diet regulated according to the extent of condition. Nothing for oral parenteral administration of fluids will be given and electrolytes so that the rest the gut will be provided. Total parenteral nutrition can be given by a central line or peripheral route. So TPN can be given by two routes, that is through the central line and through the peripheral line. Diet low in fats and proteins will be given so that the load in the gut will be reduced with restriction of stimulants. So stimulants will be not given. They are contraindicated like caffeine and alcohol because they can increase the pain. Pancreatic enzymes and bile salts if necessary. So if there is need a replacement of the pancreatic enzyme and bile salts, so they will be replaced. And now moving on to the surgical interventions if the medical management is ineffective. For example, jaundice persists or pseudocyst or bleeding occurs. So in case in the pancreas, the cyst formation occur, that is pseudocyst, and if there is a lot of bleeding and medications are not working, then surgery is needed. Type of surgery is determined by the cause. It depends that why pancreatitis occur and then the surgery is decided. For example, biliary tract surgery, removal of gallstones, drainage of cyst, temporary stent placement. These all can be the reason of pancreatitis. So first we will look into the cause, then we will advise the surgery. Treatment of hyperglycemia and administration of insulin as necessary. Okay, so now we have discussed we have already discussed in our PSC session in which we have seen that pancreas is responsible to produce the insulin, okay, which help in regulating the sugar level. So if pancreas is affected, so there will be hyperglycemia, increased blood sugar level, blood glucose level. So there will be need to administer insulin so that to regulate the sugar level in the body. Now moving on to the nursing care of clients with acute pancreatitis. First thing is assessment. So we will collect the detailed history of the causative factors. So what is the reason of the pancreatitis? It can be due to the gallstones. It can be due to the, cyst formation. Okay. So we have to know about the causative factor, the pain, what is the characteristic of pain, and recent weight loss. We have to always look into this because we know if there is anything wrong in the client's GIT system, so anorexia will occur. So that anorexia will be signified by the weight loss. So that we will see. Presence of jaundice, we will also see. Abdomen for rigidity and guarding. So we have to see the abdomen for rigidity because we have discussed that the abdomen will become board-like, very hard due to the peritonitis. Presence of hyperglycemia. So due to affection of the pancreas, the glucose level will increase. That will indicate that the pancreas has been affected. After the assessment, there will be planning. So what planning we will do for the patient? So we have to provide care related to the nasogastric tube. So as a patient will be on NG tube, as a patient's gut will be resting, so we have to provide the care related to the NG care tube. First, we have to observe for electrolyte imbalance manifested by clinical findings. For example, if there is electrolyte imbalance, which means there will be decreased calcium level, so tetany can be seen. Irritability, jerking, muscular twitching, mental changes, and psychotic behavior. All these things occur due to the deficiency of calcium. So we have to look into it. Observe for paralytic ileus. So there may be paralysis in the ileum, that is paralytic ileus. So we have to always observe for that. So the symptoms include nausea and vomiting, abdominal distension. And as the patient is on NG tube, the patency of tube should be maintained well. We have to monitor for hyperglycemia, that is increased blood glucose level. We have to see for this because the beta cells will be damaged in the pancreatitis. We have to monitor the vital signs because in pancreatitis, tachycardia can be seen, shallow breathing can be seen. So we have to see this, and oxygen saturation will be seen because due to tachycardia, the oxygen level can be dropped. Therefore, we will see for the oxygen saturation. Administer prescribed analgesics. So we have to administer opioids if the pain is severe. We have to maintain nothing per oral during acute stage of illness, and we have to monitor the input and output. So the goal will be to promote healing. So gut will be in the rest, and we have to make the patient nothing per oral. Place the patient in semi-forward position and encourage deep breathing and coughing to promote deeper respirations and prevent respiratory problems. So as we have seen in the clinical findings that patient will report shallow breathing, we will see tachycardia. Therefore, we will tell the patient to do deep breathing exercises so that enough oxygen will be consumed and the respiratory complications should be avoided. We have to monitor the parenteral therapy until oral feedings can be tolerated. So when we are giving total parenteral nutrition, when we are providing nasogastric liquid diet, then we have to see that if the therapy is monitored, if the input output is good, if the patient nutritional status is maintained. So these will be the interventions. We have to teach the dietary modifications, usually starting with small feedings of the low fat, non-gas producing liquids and progressing to a more liberalized diet, low in fat but high in protein and carbohydrates. If fat malabsorption is severe, supplemental vitamins A and E may be necessary. So you have to start the patient's diet, which will be in small quantity. It should be very low fat. It will be non-gas producing. And then we have to, slowly progress the diet, and we have to maintain that diet should be high in protein and carbohydrates. If there is fat malabsorption, which means that patient is not able to absorb the fat soluble vitamins, then we have to provide the supplementation of vitamin A and E. Daily supplements of calcium and zinc may be needed. If insulin secretion is impaired, American Diabetes Association, according to ADA, diet is indicated. So in ADA diet, there will be, kept in mind that calcium level and other nutritional levels will be maintained. So this we will see. We will teach the client and family importance of dietary instruction. In every disease related to GIT, the food is very important. The diet the patient is going to take is very important. So educating the patient about the diet he has to or she has to take is very important, especially avoiding alcohol, avoiding coffee, spicy foods, and heavy meals. All these things can stimulate, carcinoma formation and other complications. So we have to teach the importance of taking prescribed medications containing pancreatic enzymes. For example, amylase, lipase, trypsin. So we have to tell that patient need to take all these supplements, pancreatic enzyme, so that the digestion will be, proper. So with each meal, these medications should be taken to improve digestion of food if disease becomes chronic. So these things we have to see here. What will be the evaluation? What we are going to expect at the ending? So the patient reports that there is decrease in the pain level. Patient maintains the nutritional status. It means that we have provided good amount of NG feeding. We have maintained the nutritional status. Patient demonstrates adequate deep breathing or respirations. Patient maintains fluid and electrolyte balance, and patient maintains serum glucose levels with ordered range. So these are the evaluation that we are going to expect. Now, moving on to the cancer of pancreas. So, what is the cancer of pancreas? I think this slide has left, which is planning and implementation. So, this is the slide similar to this one. It is doubled. So, this is same to this. Now, moving on to the last disease of this video of the GIT system, that is cancer of pancreas. So cancer of pancreas means that there will be tumor in the pancreas. Okay, so there will be formation of tumor in the pancreas. So what is the etiology and pathophysiology? So this is the malignant growth from epithelium or ductal system producing cells that block pancreatic ducts. Okay, so fibrosis, pancreatitis, and obstruction of pancreatic duct can lead to cancer of pancreas. Lesion metastasis by direct extension to duodenal walls, splenic flexure of colon, posterior stomach wall, and common bile duct. So the lesion that is the tumor of pancreas can extend to the duodenal wall, the spleen, and the stomach wall, and the common bile duct. What are the risk factors? So the pancreas cancer can be due to hereditary, it can be due to environmental toxins, it can be due to alcohol abuse and high fat diet and smoking, chronic pancreatitis, and diabetes mellitus. So all these are the risk factors of the cancer of pancreas. Incidence is higher in middle-aged men than the women. Now, what are the clinical findings? So, patient will report anxiety, depression, anorexia, nausea, dull, achy pain, progressing to severe pain, pruritus associated with the jaundice. So, all these things the patient will report, as the patient will have a poor digestion, a stomach will be upset, so the depression, anxiety will be seen in the patient. What we will find, what will be objective data? We will see jaundice. So as the pancreas is not functioning properly, so bilirubin will be not able to process. Weight loss will be seen due to anorexia. Diarrhea and steatorrhea will be seen due to fluid and electrolyte imbalance due to anorexia. Clay-colored stools will be seen, dark urine, and ascites can be seen. That is, there will be, filling of the fluid in the abdominal cavity. Decrease serum amylase and lipase level because of decreased secretion of the enzymes. Increase serum bilirubin and alkaline phosphate level when biliary ducts are obstructed. So when the biliary duct will be obstructed, so all the bilirubin will accumulate, that will lead to increased level in the body because it will be not able to process. Now, what will be the therapeutic interventions we will see in this patient? We have to see this. In patient having cancer of pancreas, we have to monitor the glucose level and insulin replacement to control the hyperglycemia. Okay, so as the pancreas is not functioning properly, so to maintain the blood glucose level, insulin should be administered. Drug therapy. So in drug therapy, pancreatic enzyme will be given so that the digestion will be smooth. Bile salts will be given because they will be also deficient, and vitamin K will be given to control the deficiencies or bleeding. Analgesics and tranquilizers will be given for the pain. Biliary stent may be used to relieve jaundice. So if there is jaundice, then biliary stent will be, placed in the pancreas. So biliary stent looks like, a small device, a small hollow device. Biliary stents refer to the insertion of stents, which are tubes. These are made up of the plastic or metal, and they are inserted in the pancreas to relieve the obstruction in the biliary tree or to treat the biliary leaks. If there is a something obstructed in the biliary, so stents will be applied so that the functioning will be smooth and to remove the jaundice. Preparation for surgical intervention. When we need surgical intervention in the patient having cancer, so what preparation we will do? So RBC and blood volume replacement, medications to correct coagulation problems and nutritional deficiencies. So when because it is a pancreas cancer, so the treatment of choice is surgery. So before surgery, we have to see if patient's blood level is, good. If patient has, some coagulation problems, we have to solve that. We have to solve all the nutritional deficiency. So these things we have to prepare in the client. After doing so, that we have to do the surgery. The surgery is the only treatment of choice because this cancer in the pancreas has a high chance of metastasis. So that's why we have to do the surgery. All the post-surgical prognosis is a grim. So we have to remember here that the post-surgical prognosis will be very poor, but we have to do the surgery. So the surgery we have to do here is that is very common and very important is Whipple procedure. Now, what is a Whipple procedure? It is removal of head of pancreas, duodenum, portion of the stomach, and common bile duct. So we can see here that when head of the pancreas, the common bile duct some part, the duodenum some part is removed. Okay, so that is, and some portion of the stomach, all these things are removed. Then they are, resection is done. This is the Whipple procedure. We have to see this, we have to remember this. In Whipple procedure, the head of the pancreas, some part of the stomach, and some part of the common bile duct, some part of the duodenum will be removed. So from this area to this area, everything will be removed, and then they will be connected directly to this portion. This is Whipple procedure. Next will be distal pancreatectomy and splenectomy or cholecystogegnostomy. In cholecystogegnostomy, creation of an opening between gallbladder and jejunum to direct bile flow. So there will be opening made between the gallbladder and the jejunum. So we can see here, this is cholecystogegnostomy. In here, gallbladder is joined with the stomach, that will make a common passage. So here, the opening will be created between the gallbladder and the jejunum to direct the flow. So gallbladder and jejunum are resectioned. Now moving on to the palliative surgery, that will be the end, when patient will be on the end term of the disease. So biliary and gastric pass can be done. Chemotherapy and radiation when surgery is not possible or desired. Okay, so if patient do not desire to have surgery, if there is something complicated, then we can start chemotherapy to provide comfort, or in conjunction with the surgery. So it can be combined with the surgery to limit the metastasis. Chemotherapy in this gemcitabine, that is Gemzar, erlotinib, that is Tarceva, often used along with gemcitabine. So Tarceva and gemcitabine are used commonly. Metronomic chemotherapy, that is small doses over a period of several days, has potential to affect cancerous cells as they are dividing. So these medications can be useful in the patient having cancer of pancreas. Intra-arterial chemotherapy can be done. So anti-cancer drugs delivered directly into the pancreas. This is also used. Immunotherapy can be done. So uses immune system to directly or indirectly fight the cancer. So these all, management procedures can be combined with each other to have an effective result in the patient. Now, what will be nursing care of client with cancer of pancreas? So we have to assess the client for presence of jaundice, for the presence of stool for clay color, urine for dark amber color and frothy appearance, abdomen for enlargement of liver and gallbladder, characteristics of the pain, history of anorexia, nausea, and weight loss, abdominal dullness on percussion indicating early ascites. So there will be dullness in the abdomen on percussion, then it will indicate early ascites. So all these things are associated with the dysfunctioning of the pancreas. For example, there will be jaundice formation, there will be clay colored stool, dark colored urine, and distension of the abdomen. We have to look for the pain. All these things we have to assess. What will be the planning? First of all, in patient having cancer, emotional support is very, very important. We have to provide emotional support for client and family. Set realistic goals. We have to not give them false hopes. So we have to make them familiar that what can be consequences, what is the prognosis, all things should be clear. Administer analgesics as prescribed and as soon as needed to promote rest and comfort. Okay, so analgesic should be prescribed as prescribed, should be given on time so that the comfort should be maintained. Use soapless bathing. Okay, we have to use soapless breathing. The soap should not be used because there is pruritus in the patient, so skin infection can be seen. Therefore, antibiotic agent should be applied and soapless bathing should be done. Observe for complications such as peritonitis, gastrointestinal obstruction, jaundice, hyperglycemia, and hypotension. All these complications are present, therefore they should be observed. Observe stools for undigested fat, that is steatorrhea, should be also observed. Observe for wound hemorrhage caused by coagulation deficiency. If patient is lacking vitamin K, because due to dysfunctioning of the pancreas, dysfunctioning of the GIT system, there can be decrease in the fat absorption power and can lead to vitamin K deficiency. So coagulation power can decrease and it can lead to wound hemorrhage. So this should be observed and we have to administer vitamin K parenterally as prescribed. We have to encourage coughing, turning, and deep breathing. And we have to monitor for the respiratory tract infections caused by limited chest expansion. So patient will have shallow breathing, patient will have tachycardia. Therefore, we have to maintain the proper respirations in the patient and we have to avoid the respiratory tract infection resulting from the pain at site of incision. As the patient will have pain at the incision site, so patient will try to take small breaths and that can lead to respiratory tract infection. We have to monitor the input and output. We have to measure the abdominal girth to see if ascites is present or not. We have to observe for chemotherapeutic and radiation side effects. So as we all know that there are many side effects of the chemotherapy, for example, skin irritation, anorexia, nausea, vomiting. So all these should be observed. We have to maintain skin markings for radiation therapy. We have to also see that the skin markings that are applied for the radiation therapy should be maintained. We have to provide care after the pancreatic surgery. So after pancreatic surgery, what is the care that should be provided? So we have to monitor and maintain mechanical ventilation. So due to the incision, there can be shallow respiration, there can be a respiratory problem. So mechanical ventilation, we have to monitor and maintain. Monitor and maintain patency of multiple drainage tubes and venous and arterial lines. So patient may be on various drainage tubes and venous and arterial lines. Therefore, all these tubing should be in place, they should be intact, they should be not kinking, and they should be working properly. You have to monitor the patient for hyperglycemia and malabsorption syndrome, and we have to administer insulin if required. We have to monitor for delayed wound healing because of vitamin K deficiency, and it may be at risk because of hyperglycemia. So due to hyperglycemia, wound healing can be delayed. So we have to also monitor that. We have to monitor for hemorrhage, vascular collapse, and hepatorenal failure. We have to prevent infection, that is, we have to maintain the skin integrity, protect integrity of surgical incision. We have to use sterile technique when changing dressing. We have to meet the emotional needs during this critical and stressful post-operative period. So as this is a cancer, then there will be many procedures, there will be many things that we have to take care of. Patient will be very stressful, patient will have emotional outbursts. So we have to handle all these things to provide emotional support to the patient. We have to support natural defense mechanism by encouraging frequent or supplementing feeding of high nutrient density foods. We have to encourage immune stimulating nutrients, especially vitamin A and C and E and mineral selenium. So we have to boost the immunity of patient. It should be done naturally and also by the supplements, so that the patient will be able to fight with the foreign body. We have to control the nausea and vomiting before feedings if possible. We have to administer vitamin supplements, bile salts, and pancreatic enzymes as prescribed. We have to provide oral hygiene and maintain a pleasant environment, especially at mealtime. So the patient will be on NG tube, therefore oral hygiene should be maintained properly. There should be, mouthwash provided to the patient, and we have to maintain a pleasant environment to reduce the stress and stressor. Now, what will be the evaluation? What we are going to expect at the ending? So the patient will state that pain is controlled. They will be maintained nutrition status. They will be maintained fluid and electrolyte balance. The patient discusses feelings and concerns. It means that patient is not holding anything. Patient is accepting the situation. Patient is, discussing the further things. So this indicates that mental health is good. Patient will be able to maintain serum glucose levels within the ordered range, and the infection will be avoided. So all these things will be evaluated at the ending. So this is all about this video. We have discussed around 4 diseases in this video. I hope that everything we discussed was helpful and you understood all the points. If still there is any doubt, you can let me know in the comment box and we will see there. And we will discuss some more GIT problems in the next video, as this is a very detailed chapter and everything is important. Therefore, we will continue this session in our next video. Till then, keep practicing the questions and keep reading and studying. Thank you.